Good evening, everyone. Welcome to the Valley. We're honored to have you all here for the Powerhouse GI Squad. I told the other two rooms that the actual party was going to be in here, and I was right, and they were wrong. So we appreciate you all. The only crowd that sees the word MASH and doesn't think of a cooking technique or the old school TV show, but thinks of liver disease. So we got a lot of brains in here. We're excited. Quick housekeeping thing. We talked about the QR code. Please take a minute and scan that QR code, not only so you can sign up and make sure that you are representing your team, but we want to make sure that you can view slides, you can access today's content, put in all the questions you want in the Q&A, because you will meet these three superstars over here. Your job is to try to stump them at the end if you can. But also, arguably the most important thing to do is we want to make sure you can participate in the questions. Our three teams, Liver Lovers, Steatosis Squad, who's the virtual squad, all the hundreds of them watching, we're glad you're here. And the Liver Lovers, I say that one, Hepatic Heroes. Anyway, I'm Team Liver Lovers. I don't know if that means you like pate or you like hepatology, either one. And so we want to make sure you can participate in those polling questions. With that being said, my name is Alok Patel. I'm a pediatric hospitalist. Kids have livers too at Stanford Children's Hospital. I also work in journalism for ABC News and for the AAP. And I will tell you that my journalism brain talks to my adult GI counterparts all the time because everything related to GI is all over headlines these days. But let me pass it over, have our squad introduce themselves.
Thank you so much. I feel you walk in the wrong room. Welcome. So I'm Mazen Nuruddin. I'm a hepatologist in Houston, Texas. And I'm accompanied today by two of my good friends. I'm going to start with Dr. Gunn, Nadej Gunn. She's also from Texas. She's an assistant professor at Texas A&M, and she is a well-known researcher in the MASH field. By the way, how many people are here from Texas, the best state in the country?
Whoa, fighting words.
They're not here tonight. Maybe they are the online team. But also, I have also my good friend, Dr. Naeem Al-Khoury, award-renowned MASH researcher and a hepatologist. So it's going to be fun tonight, and let's see what is next. So I think the first talk will be by Dr. Gunn. She's going to talk about the MASH risk stratification.
Well, we'll run through the first agenda before we do that. We got risk stratification. Then we'll move into Dr. Al-Khoury. We'll talk about patient identification. And then Dr. Nuruddin will wrap it up with cases and context. And then we get the Q&A. I want to make sure we test drive this polling game that we're going to play. So first question for all of you. As an Arizona native, get your teams ready.
Big picture of this.
Steatosis Squad looks angry. Not anymore. Dr. Nuruddin, are you feeling any one of those three? Are you partial?
I like the one who is jumping all over the place.
Okay. So to get your polling brains fired up, no pun intended, the hottest temperature ever recorded in Phoenix, Arizona occurred on June 26, 1990. I was a 5-year-old here. Even I remember this. How hot was it? 116, 118, 120, 122 degrees Fahrenheit. What do you all think? Okay, the correct answer was 122 degrees. That's pretty hot, but I think 70 days above 110 is worse, which was last year. Steatosis Squad. Yeah. I trust they were not using ChatGPT. Got that one right. So moving on, I'm going to pass it off to Dr. Gunn to talk about MASH risk stratification. The round one categories are going to be, is it MASH, risk of progression, pathophysiology, and risk assessment. Dr. Gunn, take it away.
So we're going to start with a question.
I'll read the question. You're right. 49-year-old, no significant past medical history, presents for elevated liver enzymes. You can read them there. He admits to drinking 2 beers daily, 14 beers a week. Upon further questioning, tells you each beer is 24 ounces with an alcohol content of 8%. I am curious what those beers are. What is your diagnosis? Is it AMSLD, MASH. 2, Met ALD, or acute alcoholic hepatitis.
All right, let's get it.
Liver lovers who may not love their livers too much if they're drinking 24 ounces of beer 14 times a week. My team came through.
Perfect. Excellent, excellent job. You cannot start a conversation about metabolic dysfunction associated steatotic liver disease without touching base on alcohol. And this was one of my favorite things to do as a military fellow, was interview my veterans about how much alcohol they were drinking. And they would say, I'd say, hey, Sergeant Smith, how much alcohol do you drink? And they'd say, ma'am, 2, 3, 6, 7. And I said, what does that mean? What does that mean? So firstly, we have to understand the differences between when we're talking about a purely metabolic issue versus something in between when alcohol is in the setting or pure alcohol-related liver disease. Remember, a drink is a drink is a drink, whether it is a 5-ounce glass of wine, a 1.5-ounce shot of liquor, or a 12-ounce can of beer. Each of those here in the US have 14 grams of alcohol. So it's very important that you're communicating to the patients that beer is no worse than wine and wine is no worse. They're all the same. The other piece to understand is the NIAA, excuse me, my clicker is not working here. Okay, here we go. The NIAA does subscribe to explaining to us what excess alcohol looks like, and greater than 4 drinks a day for a male or greater than 3 drinks a day for a woman is considered excessive alcohol. And our guidelines and what we believe also align very close to that. So it's very important that we understand what the quantity of alcohol is that our patients are drinking. I would say, and I would take some time to listen to the terminology that your patients are using. They say jigger, handle, a fifth, a nip, whatever it is, and understand what the volumes are. Now we have PEth tests that we can use to help us to identify those who may be drinking in harmful quantities. So very important for us to keep this in mind. Now, you know the nomenclature for MASLD and MASH changed in June of 2023. We used to call this condition non-alcoholic fatty liver, but that was changed due to stigma and also because we needed a more precise definition for what exactly MASLD and MASH was. And so that umbrella term is steatotic liver disease. And then you go down and break it to what exactly is the fat coming from? What exactly is the steatosis due to? If it's MASLD, that means fat in the liver is due to one or more cardiometabolic risks, whether that is diabetes, high blood pressure, dyslipidemia, etc. When we call it Met ALD, that is someone living with fat in the liver plus a metabolic condition, but in addition, they're drinking as a female anywhere between 20 to 50 grams of alcohol per day, and for a man, anywhere between 30 to 60 grams of alcohol per day. Remember, as I mentioned earlier, 1 unit of alcohol is 14 grams in each component. If it's alcohol-related liver disease, however, now that alcohol consumption is much more advanced with greater than 50 grams per day in a woman and greater than 60 grams per day in a man. So it's really important as you're meeting your patients that you are stratifying and defining exactly what they're doing when it comes to their liver and what exactly is the etiology of their liver disease. Other causes of steatotic liver disease, as you can see on the right, could be medication or a genetic or other cryptogenic, et cetera. Now, I do want to highlight this cardiometabolic risk stratification for our patients. So if we're going to call it MASLD, remember that is fat in the liver in addition to 1 cardiometabolic risk. But take a minute to look at the risk. 1 is BMI, right? We know greater than or equal to 25 on average is what we consider overweight, but we do have ethnic cut points that are different. And also waist circumference takes some responsibility here as well. So if it's a waist circumference that's larger or the BMI, you can use either or to make that person meet that criteria. Also diabetes, pre-diabetes, blood pressure, dyslipidemia, any one of those listed in conjunction with steatosis in the liver is what we would call MASLD. Now the new nomenclature helps us to really recognize what MASH is, right? We know that MASH is a histologic definition. When a pathologist looks under the microscope at a piece of liver, they want to see 3 things. They want to see steatosis fat, They want to see inflammation, and they want to see those characteristic cells that we call ballooned hepatocytes. These are expanded swollen liver cells that are on the brink of necrosis. That is what we call MASH. And they ascribe a certain point system, as you can see in the center, where steatosis gets up to 3 points, ballooning gets up to 2, and lobular inflammation gets up to 3 for a composite score total of 8. And if a patient hits 4 or more, that is MASH. But the piece that really we want to drive home here is that at-risk MASH category. When an individual has developed MASH and fibrosis ensues at F2, F3, this is where all-cause mortality, liver-related mortality, cardiovascular mortality increase, and this is where we want to identify patients because we can hopefully turn back the hands of time on these individuals so we can save lives and prevent the progression of cirrhosis. So now when you're diagnosing MASLD, as any card-carrying hepatologist or GI or clinician working in the space, you want to rule out other diseases. But once you know someone has steatosis in the liver, whether that's identified by imaging, ultrasound, maybe an elastography that has a parameter that measures for fat, or maybe it's an MRI with a proton density fat fraction, or perhaps it's a biopsy that tells you there is fat in this liver, then you want to ask yourself, does the patient have a cardiometabolic risk, as I showed you earlier? If the answer is yes, ensure there's no other cause for steatosis in their liver, and now you have the diagnosis of MASLD. If there's alcohol in play, you want to know how much, so you can then define it as either MET ALD or purely alcohol-related liver disease. Then on the flip side of that, if you can answer yes to the cardiometabolic criteria, then of course you want to entertain other causes for steatosis. Maybe it's cryptogenic or medicine. Just not to belabor this, but we really want to ensure that you're following that logical progression when it comes to diagnosing MASLD. And now I'll flip it back to Dr. Patel.
Dr. Gunn, thank you. I want to get a shirt or a PSA that says a drink is a drink is a drink. I like that. So you've been able to identify MASH. We're going to move on to risk of progression, which means teams, you have another chance to battle, and I feel like the hepatic heroes need to win one, but let's go. What is the approximate annual risk of progression from MASH to cirrhosis? 1 to 2%, 1 to 10%, 7% to 15%, or 15 to 20%?
All right, let's get it.
The steatosis squad is so angry, the other two are so happy. Oh, virtual came through again.
All right.
Dr. Gunn, back to you.
Okay, so the correct answer is 1 to 10%. And this was a nice publication that came out this year, New England Journal of Medicine. Targer and colleagues out of Italy published this nice natural history epidemiology of MASLD and MASH. And basically what they helped us understand was that a healthy liver, when the right situation is at play, whether it's genetics, PNPLA3 for instance, epigenetics, metabolic syndrome, poor diet, high fructose, et cetera, that then promotes fat in the liver at a 5% per year annual risk. Once isolated steatosis ensues, then you have a 7 to 35% annual risk of developing MASH. Once MASH is at play, that's where that 1 to 10% per year annual risk of cirrhosis comes into play. But what you want to know about that range sounds very wide, and you know that we don't know how quickly people are going to progress. That is still something we really question day after day. If I see someone with F2 fibrosis today, how likely are they going to have advanced cirrhosis in a year or two? And since there's such an unpredictable nature of this disease, we want to make sure we're routinely seeing these patients, screening them, and monitoring them over time. But one very important call out on this slide is that progression to liver cancer. We know that we want to screen anyone who has cirrhosis, no matter what the etiology is, for cancer. And there's no exception in MASH. But what you see here in that jumping arrow from MASH to HCC, in the absence of cirrhosis, there's still a risk of HCC. And so we really have to keep that at heart because this disease can cause cancer even in the absence of cirrhosis. One other piece that was mentioned in this article, which is nice to know, is that female sex and estrogen may be protective for a while. But once you see these women become postmenopausal, they lose that protection and their incidence of MASH actually increase as they age. I'll flip it back to Dr. Patel.
No question on this one. You all get a break. We're moving on to pathophysiology. Dr. Gunn, I got a pretty diagram for you to take on.
Now, this is too much. I'm going to just tell you this right now. this has too much going on, but the piece that this is trying to communicate is that MASLD and MASH is highly complex. You're taking fat in the liver, it's toxic, it's destroying the liver cells, it's activating hepatic stellate cells, collagen is being deposed, and then fibrosis ensues, liver cancer, liver failure, etc. But what's promising about this slide is that you see all these therapeutic targets. Everyone is trying to jump in to see if we can stop this inflammatory cascade. And we're very fortunate that here in the last year or last couple of years, we've had drugs like the thyroid hormone beta receptor agonist that gets those mitochondria to get rid of intrahepatic triglycerides, and the GLP-1s that help with body weight, cardiovascular outcomes, and insulin resistance, all helping to make this disease less of a burden as it is at this time. And you can also see other mechanisms that are in clinical development in this very complicated slide.
That gave me like
Back to you.
PTSD from med school, that slide. But moving on, ultimate last part of this is risk assessment for Dr. Gunn. So here's your next question. 62-year-old female patient with a past medical history of type 2 diabetes and obesity presents for elevated liver enzymes. AST 56, 68 ALT, platelets 208. You calculate her FIB4 based on the AASLD guidelines. Her score is a 2.02. What is the recommended next step in her evaluation? Is it monitor liver enzymes, repeat the test in a year, refer for liver biopsy, MRI or CT scan, or a VCTE? There is no all of the above, sorry. Don't let the virtual team get this one right again. I mean, they can get it right, but I need my liver lovers to love it up. Okay.
Very, very nicely done. So that tells me that most of you in this room know that we need to look at sequential non-invasive tests to assess the fibrosis risk in our patients. And the AASLD provided this 2023 guidance that helped to break it down by what we would expect from our primary care or non-GI hepatology colleagues, and then when they should bring us in to the conversation. The FIB4 is that nice global population screening test. It has its limitations, but if that FIB4 is 1.3 or higher, that necessitates a next NIT or non-invasive test in sequence to help us stratify the patients. If that VCTE or elastography is 8 or higher, or the ELF score greater than 7.7, this is where they would then consult with a specialist to further take it from there, whether that is to do another non-invasive test like an MRE or maybe an invasive test like a liver biopsy. Whatever the case, the baton is passed to the hepatology. Now we know not only has the AASLD provided us guidance, we see endocrinology societies, diabetes, cardiovascular societies also adding to this conversation. But what's also nice is the AGA with the 2023 guidance, they give us a little bit of flexibility here. They bring in some more non-invasive tests. They talk about individuals living with diabetes because they're so high risk for MASH that maybe even in the presence of a normal FIB4, you might want to go ahead and get another non-invasive. You're well within your rights to do that. They also mention that FIB4 has its limitations, especially at the extremes of age. So as we know, the FIB4 cutoff is 1.3 for someone within the 35 to 65 age category. But once they exceed age 65, you can make that cut point for abnormal greater than 2.0. So this is all communicated in this guideline, but ultimately what they're all going after is sequential non-invasive tests, starting with a FIB4, then adding either a VCTE, vibration-controlled transient elastography, or an ELF, or maybe even an MR elastography if you so choose. And if that patient has F2, F3 fibrosis by these non-invasive measures, then this is someone who could be linked to care, pharmacotherapy can be added for that patient. And then remember, all of the guidelines tell us that even in the setting of a normal FIB-4, at the point in which you assess, you still want to follow that patient, reassess in a year or 2 years to ensure you don't miss something dangerous happening behind the scenes. Thank you for your attention. We'll move on to the next.
Dr. Gunn, thank you. This pediatrician obviously is partial to non-invasive tests. So before Dr. Alkhoury takes it away, we're going to give you a quick lay of the land of round 2 categories: blood-based tests, imaging tests, combination tests, who should get MASH therapy, and assessing treatment response. So first up, we're going to talk about blood-based tests. Get your thinking caps fired up. 59-year-old man with obesity, type 2 diabetes, is undergoing evaluation for MASH. I don't know if you all call this an ELF or an ELF. I'm calling it ELF because that sounds fun. His ELF test returns a score of 9.9. Which option best describes his degree of fibrosis based on this result? Is it a low likelihood of clinical fibrosis? We're giving good news. Moderate fibrosis, F2, advanced fibrosis, F3, or are we toast? Is it cirrhosis, F4? I feel like I'm rooting for the hepatic heroes now. You guys got to take one of these.
All right, well,
audience,
this is good. You guys got it right, F3. So, ELF more than 9.8 typically is consistent with F3 fibrosis, advanced fibrosis. And who won this one? Steatosis squad, right?
I think they're cheating. I'm kidding. Okay. You
All
guys are brilliant. Y'all are brilliant.
All right, so before I get started, let me see, show of hands, how many people are here from the East Coast? Okay, well, you guys won this competition already. Thank you so much for staying up. It's almost midnight for you guys, so we appreciate you being here. So when we talk about non-invasive tests, we call them NITs to determine the fibrosis stage. And we break these down into serologic, blood-based, including some simple scores like FIB-4 that Dr. Gunn mentioned. And I think this is the simplest one that you can calculate. It's available in some EMRs. So if you do .FIB-4, it will give you the calculation. And then we have the ELF one, or the enhanced liver fibrosis one. This is a send-out test, but it's commercially available. And let me see, show of hands, how many of you guys have ordered an ELF test on a patient? Okay, we have a few people here. It's available in the United States. In the right patients, typically it's covered by insurance, so I encourage you to look into it in your community. And then we have imaging-based tests. They rely on measuring liver elastography, so you're measuring the stiffness of the liver as a surrogate for liver fibrosis. This includes vibration-controlled transient elastography. This could be done with the FibroScan machine or similar machines. You can also do MR elastography and a new test called CT1, which is actually an MRI-based test. It's corrected T1. I'll explain it in the next slides. If you want to dig deeper into the non-invasive tests, you can actually go to the AASLD website. They have this, they call them NILDA, which is another way to say non-invasive liver diagnostics. And basically, they look at the performance of FIB-4 and liver stiffness with VCTE, MRI, and MASLD, MASH, but also other liver diseases. So this is a very long document, a very good one to read, and I highly advise you to look into it if you want to dig deeper into NITs. But let's go back to FIB-4. So again, this is a simple calculation. It has age because older patients are more likely to have advanced disease. You have your AST to ALT ratio, because as you get to F3, F4, typically your AST becomes closer to the ALT or sometimes higher. And then you have your platelet count, because when you progress to cirrhosis, your platelets go down. So that's the rationale for having these 4 variables. If your FIB-4 is less than 1.3, you're considered lower risk. You stay in primary care. You focus on managing obesity and metabolic syndrome. More than 2.67, this is a high-risk patient. In between, you need a sequential test. This is the ELF test, enhanced liver fibrosis. It has 3 biomarkers in it. Long names, hyaluronic acid, procollagen 3, and tissue inhibitor of metalloproteinase 1, or TIMP1. Don't worry about remembering these names. Just know that when you order the ELF test, you're going to get a number, and that number will correspond to your fibrosis stage, but also it has prognostic value. So if your ELF is less than 7.7, you're not going to have significant fibrosis. Once you get to 9.8, this is when I start worrying about advanced fibrosis, F3. More than 11.3, this is consistent with stage 4 or cirrhosis. As I mentioned, ELF has its own prognostic value. So if you have an ELF between 9.8 to 11.3, this indicates higher chances of progression to cirrhosis. And then ELF more than 11.3 in cirrhotic patients also indicates higher chances of decompensation, developing ascites, hepatic encephalopathy, variceal bleeding. So in addition to determining the fibrosis stage, you get prognostic value with ELF. All right, round two.
We're gonna give our teams another shot here before we move on to imaging tests. Get ready to battle. 62-year-old Hispanic male with a past medical history, type 2 diabetes, obesity, OSA, and hypertension presents with elevated liver enzymes. I won't read them all, they're right there. You have a FIB4 score of 3.92, VCTE shows the following, CAP of 321, LSM of 18.9. How likely is it that this patient has cirrhosis? Very likely, somewhat likely. I feel like I identify with the emotions of this one. I need a liver biopsy before deciding. Or not likely at all, this patient does not have cirrhosis. Kind of definitive.
I like these choices.
I do. I like the relatability in them.
Yes.
Who's gonna beat the virtual? Dang, they're solid.
Excellent, excellent, guys. So this is a patient that has very high probability of having cirrhosis. Let me see, can I go back one slide or no? No going back, okay, no problem. So this is liver stiffness, what we call vibration-controlled transient elastography. And basically what we do with this machine, you're basically tapping on the liver, inducing what we call a shear wave. And you're going to follow this wave as it propagates through the liver tissue. If you have a healthy liver without fibrosis, you're going to have actually a very slow wave, and this will lead to low liver stiffness, and that tells you there is no significant fibrosis. When you have a fibrotic liver, the liver is going to become stiff, and the wave will travel quickly through the liver tissue, and that will tell you that you have significant fibrosis. The range for liver stiffness is between 2.5 to 75 kilopascals, and anything above 6 kilopascals typically indicates some fibrosis. Once you get to 8, this is significant fibrosis. Anything over 15 typically indicates cirrhosis. And here you see from a famous paper that we quote all the time, the performance of transient elastography. And the one point I wanted to highlight, if you look at distinguishing F4 from other fibrosis stages, and if you look at the last row in terms of negative predictive value, FibroScan is very good at telling you that the patient does not have cirrhosis. But when you look at the positive predictive value, you can see it's around 30%. So you could be overestimating in some cases with just relying on one transient elastography measurement. That's why we always emphasize the need to look at the entire picture. How old is the patient? Do they have low platelet count? What's the AST to ALT ratio? All of these things will give you a pretest probability of potentially having cirrhosis. Then if you get high liver stiffness, I believe it. If the pretest probability is very low, it's a young patient with low liver enzymes, very high platelet count, then you have to take it with a grain of salt. With the transient elastography machine also, you get a second number. We call it the controlled attenuation parameter. This gives you the amount of steatosis in the liver. And if you want to understand the physics, you are looking at the attenuation of the wave. So when you don't have steatosis in the liver, the wave will attenuate slowly. It will travel a long distance in the liver tissue. And this tells you have a healthy liver. When you have elevated steatosis, you're going to see fast attenuation. The wave doesn't travel that far, and this will tell you that you have a steatotic liver. So this slide is basically transient elastography interpretation for the non-experts, very simplified. But when you have a CAPS score, steatosis score more than 275, that typically indicates significant steatosis. And then when you look at the transient elastography, liver stiffness, less than 6 kilopascal is no fibrosis, 6 to 8 is stage 1, 8 to 10 is stage 2, 10 to 14 is stage 3, and then more than 14, 15 is cirrhosis. We also have great MR technologies to quantify liver fat and also determine the stage of fibrosis. So for steatosis, we rely on MRI PDFF, proton density fat fraction. You get a percentage of steatosis. Anything more than 5% is considered steatosis in the liver. And this is actually the most accurate way to quantify liver steatosis. The repeatability is great, and you can also use it to assess response to treatment with certain medications. MR elastography is the other way to determine liver stiffness and determine the fibrosis stage. You have to induce these shear waves in the liver, and typically you get a number in kilopascals, but the values are much lower than what you get with the transient elastography machine. MRE stiffness more than 3.7 typically indicates advanced fibrosis. As a simple rule, to convert MR elastography to transient elastography liver stiffness, you multiply the MRI values by 3.5, and that will give you a quick idea. Corrected T1 or CT1 MRI, this is part of what we call the liver multi-scan. This is a way where we can actually determine the presence of fibroinflammation, so not just fibrosis, but also inflammation in the liver. And the idea here is that your T1 signaling on MRI will give you an idea about inflammation and fibrosis in the liver. But if you have extra iron deposition in the liver, that can decrease your T1 signal, so you have to correct for the iron content. That's why we call it corrected T1. And again, you'll get a number in milliseconds, and that will tell you how much fibroinflammation you have in the liver. So CT1 less than 800 milliseconds indicates the absence of at-risk MASH or MASH with F2 and higher. CT1 more than 875 milliseconds indicates the presence of at-risk MASH. In between, you can have MASH, but typically no significant fibrosis.
And
right,
we can move on to combination tests. This is an important question because after this, we're going to take a look at the leaderboard. What parameters are used to calculate the FAST score? I'll let you read those because I'm not going to read all those acronyms. But what combination here, what algorithm is going to get you the FAST score?
That's a difficult one. Let's see.
ChatGPT 5.0 might be able to do it. Might, though. Might. I don't know. Whoa.
Okay, you guys are good. Did you listen to this lecture before? I'm impressed. Okay.
I'm curious to hear your thoughts, Dr. Alkhoury, but let's take a look at the leaderboard and see where we're at on this.
Okay.
Liver lovers.
Lovers. Okay, well, they still have a chance, right, to change this. So
We're
competition
early.
is still
We're early.
happening.
We're like at halftime.
Okay.
But take it away, sir.
So speaking of ChatGPT, true story, I was in clinic the other day and I had a transient elastography value for a patient that was around 11.5. So I go in, I do my spiel and show him fibrosis stages, and I'm like, probably you have stage 3. And the patient is like, before you walked in, I consulted with my AI and he told me exactly this, and I knew I had F3 and I'm ready for treatment. I'm like, okay, that's great. So it's happening already in the clinic, and yeah, people are consulting their AI. And he said, my AI. I'm like, what's your AI? He's like, oh, ChatGPT. So that's the world we live in. All right, so the FAST score. This is a great score. It tells you if you have at-risk MASH. And to calculate the FAST score, you need your CAP score for steatosis. You need your AST, the liver enzyme, which gives you an idea about disease activity, inflammation. And you need your VCTE, liver stiffness measurements, the KPA number to determine fibrosis stage. You put these 3 numbers in this a very simple mathematical equation. I want you guys to memorize it. No, anyway, you have a phone app that can calculate this for you. But you get a FAST score, very simple. You get it from 0 to 1. The closer you are to 1, the more likely you have at-risk MASH, which is MASH with significant fibrosis. But we have a rule-out cut point. If your FAST is less than 0.35, you don't have at-risk MASH. If your FAST score is more than 0.67, you have very high likelihood of having at-risk MASH, and these are patients that will benefit from pharmacologic treatment. If in between, then you may need to do another test. And by the way, FAST stands for FibroScan plus AST. With FibroScan, you get your CAP and VCTE. We also developed a score with Dr. Nuruddin called the MAST score. So this stands for MRI and AST. And with the MAST, basically, instead of CAP, you do MRI PDFF, which we believe is more accurate. Instead of transient elastography, you do MR elastography, and you still have your AST liver enzymes. And this is from the original paper for the MAST score, and you can see the ROC curve, and you can see the comparison to other non-invasive tests. But this is a score that you can calculate on a website, and the website is called coulditbemash.org. Okay, one word, coulditbemash.org. It's actually a very nice website to help you interpret MRI results for PDFF, MR elastography. But you can also calculate the MAST score, and it gives you a visual interpretation if you're high risk or low risk patient. And again, MAST score does the same thing you get with the FAST score. You determine if they have MASH with significant fibrosis, what we call at-risk MASH.
And Dr. Alcoa, you have that math equation memorized, right?
Yeah,
you can
of
just
course.
whip it out tonight later.
Yeah.
Anyway, before we get into the next categories, just a quick reminder to submit questions for these three right on the panel. We should have time at the end. Stump them, ask them whatever you want. Next up, who should get MASH treatment? Let's read this question. 53-year-old woman with a history of type 2 diabetes, obesity, and fatty liver disease, confirmed on ultrasound. She undergoes VCTE, which reveals a score of 11.2. Her platelets are 255,000. Is this patient a candidate for liver-directed MASH therapy? No, her platelets are too high. No, her VCT is too low. Possibly, but she needs a liver biopsy to confirm. Yes, she's an appropriate candidate. I'm sensing a progression of like the kind of confidence in these numbers.
Okay, excellent. Yes, she will be a perfect candidate for treatment. And we have 2 FDA-approved treatments now in the United States for MASH with F2, F3 fibrosis, what we call moderate to advanced fibrosis. The FDA just recently, on August 15th, approved semaglutide, the GLP-1 receptor agonist, again, in adults with F2, F3. None of the medications are approved to treat cirrhotic patients with F4. And this is the obesity dose for semaglutide, so you up-titrate to 2.4 milligrams weekly. Of course, you guys know the contraindications for semaglutide is, patients with history of medullary thyroid carcinoma, even if there's a family history of this, or MEN2 syndrome, and patients with pancreatitis may not be suitable candidates, and of course, if you have a hypersensitivity to semaglutide. Of course, the other medication is resmetirom, the thyroid hormone receptor beta agonist. This was approved in March 2024. And after the approval of resmetirom, a group of experts got together to help providers select patients for treatment based on non-invasive tests. So we created this traffic light concept. Basically, you can utilize different non-invasive tests, but if you want to use transient elastography, then the green zone, the sweet spot for treating patients is having liver stiffness between 10 to 15 kilopascal. If you want to use MR elastography, it was 3.3 to 4.2, and you can do the same with the ELF score. Then we have the red zone, where we say don't treat because these patients are likely to be cirrhotics, and this will be someone with transient elastography more than 20 kilopascal. And then we have the yellow zone. For example, if your transient elastography is between 15 to 20, actually some of these patients will have cirrhosis, but many of them will have F3 fibrosis fibrosis. So you need to do abdominal imaging, make sure there is no nodular liver, no splenomegaly, make sure the platelet count is perfectly fine, and then you can actually treat these patients. So this is how we think about treatment. This was followed by the AASLD guidance update, and they basically followed the same recommendations, although the cut points are slightly different. So they recommend that you treat patients with VCTE between 8 to 15 kilopascal as opposed to 10 to 15. But again, the same idea. You have your red zone or the no treatment zone where you have high transient elastography, and these patients are likely to be cirrhotics. And then you have the yellow zone where you need some expertise to decide if the patient is a good candidate or not. And then more recently, the American Diabetes Association released their MASL treatment algorithm. What I like about this is that they provide you with the treatment algorithm for the entire spectrum of MASL, including patients with no fibrosis, and it goes all the way to decompensated cirrhosis. But the focus here is on MASH with F2, F3 in terms of pharmacologic treatment. And it's the same recommendation, basically, that now we have two options, resmetirom and GLP-1 receptor agonist, specifically semaglutide with up titration to 2.4 milligram weekly.
And naturally, you have to follow up to see how treatment is going. So last part of round 2 is going to be assessing treatment response. Brainiacs. For a patient with MASH initiated on treatment with resmetirom, at what point should treatment discontinuation be considered if non-invasive tests are not improving? Is it 3 months, 6 months, 12 months, or we're going to go aggressive and say 18 months? Paddock here is looking jolly.
Okay, excellent. 12 months after 1 year of treatment. This is to mirror the design of the Maestro-NASH trial that led to resmetirom approval. We treated patients with biopsy-proven MASH with F2, F3 for 52 weeks, so 1 year, and then we did the assessment for response. So typically we wait 1 year to see if the patient is a responder or not. Of course, Maestro-NASH did liver biopsies at baseline, liver biopsies after 52 weeks, but in the real world, we're not going to biopsy patients 2 times. So we need to assess response to treatment to resmetirom or semaglutide using non-invasive tests. And the way I want you to think about it, you have to assess for 3 things when you assess for treatment response. Number 1 is, do I see response on steatosis? Are we decreasing the amount of liver fat? Number 2 is decreased disease activity or inflammation. And the easiest way in clinic is to see reduction in AST and ALT. And then, of course, we want to see reduction in liver fibrosis based on transient elastography or MR elastography. And I think with this also we have 3 zones. So if someone is responding in all 3, so you see a reduction in the CAP score or PDFF, reduction in transient elastography by 25% or more, and you see reduction in ALT and AST. This is a responder, and you need to continue with treatment because these patients are doing well. And then you're going to have people that don't respond, and this is when you don't see change in the ALT, it remains elevated, and then you see worsening in transient elastography or MR elastography, and this patient is a non-responder. You're going to have many patients that actually show you a reduction in potentially steatosis and ALT, but the liver stiffness remains the same. My advice is to continue treatment in these patients because the Maestro-NASH study is still ongoing for about 5 years, and we're going to see if we can prevent progression to cirrhosis in this population. So if someone started with F3 fibrosis and at the 1 year mark they still have F3, but they decrease their steatosis and ALT, I would continue to treat until we have the results of the Maestro-NASH, of course with yearly assessment to make sure that there is no worsening in the disease. Of course, when we start resmetirom, we also need to monitor for safety. So this is from the AASLD guidance update. Typically in my clinic, I have my baseline AST and ALT. Then I repeat at 3, 6, 9, and 12 months. And then you can also check a thyroid panel. I do this in patients with history of hypothyroidism. And then you can follow up on this to make sure that there are no significant changes. You should actually check your lipid profile, especially in patients on statins if you have to dose adjust the statin, and then monitor this over time. Of course, resmetirom has actually lipid-lowering properties. It can decrease your LDL cholesterol by up to 16% with the high dose 100 milligrams daily. It can also decrease your triglycerides and Lp(a), so it has beneficial lipid profile. And then, of course, we want to assess for efficacy, as we said, with non-invasive tests, including PDFF and CAP score, transient elastography, and ALT. And I think this is my last slide, but we just wanted to share with you what's the appropriate cut point to say that you are responding. So if you are utilizing MRI PDFF, you want to see at least 30% relative reduction from your baseline. If you're using ALT, we like to see a reduction by 17 units, absolute reduction. So if you start at 60, my goal is to be less than 43, and then maintain it below that threshold. If you're going to use the enhanced liver fibrosis test, ELF, you want to see a reduction by 0.5 from baseline. And then for liver stiffness, we like to see more than 30% reduction. ASLD guidelines say 25%. So I would say 25 to 30% is acceptable. But these are the thresholds that we use to say that the patient is a responder. So with this, I want to thank you for the opportunity to be here tonight and stay up for one more presentation.
They're wide awake. In this last part, Dr. Nuruddin and I are going to kind of go back and forth as we talk about cases and give you a chance to answer questions, because I know you're all burning to put this information into clinical context. So first up, we're going to run through our very first case, and then you're going to answer a question about it. This is going to be fire.
All right. I'm the last person holding you from bed, East Coast people. So let's go to bed soon. But we're finishing with clinical stuff. Who's this guy? 43 years old male patient with BMI of 41, but no type 2 diabetes or metabolic syndrome. Presents to his primary care with incidental finding of fatty liver and ultrasound done to assess for right upper quadrant pain. And I'm sure you guys are seeing more of these cases. Back in the days, people used to say, fatty liver, don't worry about it. Now they're becoming more alert and oriented to the steatosis in the liver. So the question is, are they referring correctly or not? So his ALT is 56, AST is 36, albumin is 4.4, and platelet count is 279. What do I do with this patient?
I want to see what our audience thinks. I'm curious to hear if you agree with their assessment and plan.
All right. So are we going through this question? What is the next?
What do you guys think? Refer to a hepatologist, calculate his FIB4, obtain a VCTE or ELF, obtain an MRE, call Dr. Nuruddin in the middle of the night. What are you gonna do? That's what I would do. I would just call you.
Calculate his FIB4.
You agree?
Yeah. Let's take a look. So I guess that's the message actually we should spread to your primary care. Stop referring to me just for hepatic steatosis. Let's do the FIB4. Here we go. Let's go back to the FIB4. And the FIB4 is now 0.71. And I think this guy's name is John.
John.
So we're going to see what's the next step with John. And we give you the answer. 0.71 is low. I guess Dr. Akori was talking about FIB4. So let's see the next question.
And now that it's low, now am I good? Are you going to refer to a hepatologist? Now do you obtain a VCT or ELF, obtain an MRE, or lifestyle intervention, which is one of my favorite things to say in journalism, and repeat the FIB4 in 2 to 3 years?
All right, team, this is your chance to catch up with the others and win the night. There's a gift at the end, right? There's a prize.
Yeah,
for the winners.
Emotional prize.
I love it.
From the 4 of us.
Sounds like my.
I was gonna say a drink at the bar, but this is a liver talk, so no, it's a drink of.
Sounds like a CEO
water.
of a hospital. So emotional support.
Pizza.
All right. The lifestyle intervention, I repeat FIB4 in 2 to 3 years. Absolutely correct. I don't love repeating FIB4, to be honest. This is the guidance. I think it's going to change. I don't like to repeat it in 2 to 3 years. I like to repeat it yearly. It's sitting in front of you. It's age, ALT, AST, and platelet. So just like FIB4 and EPIC or any other EMR you use, and it will pop up. But that low FIB4, you just repeat it and you ask the patient for lifestyle intervention. So the case number 2, let's take a look. Why this lady looks sad?
Maybe she's inquisitive. Maybe she's just thinking. I don't know.
I think she wants to go to sleep. 59-year-old female with BMI 42 and has metabolic syndrome. This is different from John, with elevated liver enzymes. ALT is 66, AST is 61, albumin 4.1, and platelet count is 191. All right, we know the FIB4 is 2.32, and it's intermediate or indeterminate. And the next step is a second NIT. And her FIB4 is now, I'm sorry, the next step was VCTE of 10.8 kPa. So let's see if you guys have been listening to Dr. Alkhouri or not.
So inquisitive,
Yeah.
not sleepy Susan.
All right.
She's inquisitive. She's in nature.
Inquisitive, yes.
Her FIB4 is 2.32, and her VCT is 10.8. What is the next best step for her? Obtain a confirmatory VCT or ELF, obtain an MRE or CT scan, refer for liver biopsy, or start MASH therapy, semaglutide or resmetirom. Hepatic heroes, this is your chance. I'm just saying. I'm looking at this table right here.
So who do you think?
I feel the IQ.
Who's going to win?
I'm partial to the liver lovers, but it's anyone's game, to be honest.
All right. Start MASH therapy, resmetirom or semaglutide. Yes, this patient is, the VCT is 10.8. This is a patient is in trouble and need a pharmacological therapy. And you have choices, resmetirom or semaglutide in this patient. So let's go to the next one, case 3. This guy's awake.
He's wide awake.
Right. 60-year-old male.
He's locked in.
Yes. He's diabetic. His BMI is 39, and he has metabolic syndrome. He has persistent elevated liver enzymes, and he comes to you guys. ALT is 66, AST is 76, albumin is 3.5, and platelet count is 147. Is there anything, alerting you? This is like for hepatologists, like, oh my God, there are too many wrong things. But let's take a look. Mm-hmm. The FIB4 is 3.79, and the next step is referring to a specialist. And of course, look at the platelet is abnormal. Mm-hmm. Look at the albumin. Look at the AST and ALT ratio flipped. So all these things. VCT is 21. Came to Dr. Alkhouri's office. He put the FibroScan, and the guy is keep getting in trouble deeper and deeper, right? I guess let's see what we're gonna ask you. We're getting toward the end, so questions are now very important.
I feel like we can method act. And like Bill's walking in and saying, what is the next best step for me? And you're like, is it start MASH therapy, obtain an MRE, obtain ELF, obtain an EGD? You all saw those labs and that ultrasound, probably not great. What do you think it is?
I'm curious actually what people answer this one. This is a tricky one. It could be a board question.
This is also the last question. So make sure you run away with it. Liver lovers, hepatic heroes, our virtual squad who's getting everything right for some reason.
I feel like if the steatosis squad doesn't win, bad things are gonna happen. They're very angry.
Oh, look at that.
Obtain EGD.
Nice.
All right, 42%. Good job. So this patient is, you guys heard of Baveno criteria, right? The VCT, are there any fellows in the room? You guys are shaking your heads. I like it.
I respect the bravery of this table.
Oh, yeah.
One raised their hand, the other one was like, yes, sir.
So it's the platelet of less than 150 and the FibroScan more than 20. This is clinically significant pulmonary hypertension. And we have results. This is the finale, right? The next.
This is the finale. We liver lovers.
You're right.
Take that.
Congratulations.
I did not cheat.
The happiest liver.
That's our team.
All right, liver lovers, congratulations. This is the conclusion. You can start wearing your pajamas. We're getting on, but we have to do the Q&As in your pajamas. It's like my daughter comes at the end of the night, is like, can I stay with you for 5 more minutes? 5 more minutes. Masled and MASH are increasing. We have to screen the high-risk population. Go to your primary care and tell them about FIB4, FIB4, FIB4. And this is the first step to risk stratify the patients. And then we look at the second test, VCTE more than 8. That's an indication for pharmacological therapy. These patients have increased morbidity and mortality, as Dr. Gunn said. Dr. Akori showed you what the transelastography needs to be. They need liver-directed therapies. There is resmetirom and semaglutide. Treatment decisions, stage. You need to look at the comorbidities. You need to look at other medications, statins and others, and then bring the patients to therapy and monitor them over the next year and decide on improvement in NITs therapies. Now we're gonna do Q&A questions. First question I have, and this is the great things about moderating. I ask the question, I ask my colleagues, and they answer me, and I don't have to deal with the questions. Which test is better, VCTE versus ELF? What do you usually do in your clinical practice?
I mean, I think we've been using VCTE for a while now. I call VCTE the hepatologist stethoscope, and the CAP score and liver stiffness. These are the liver vital signs. I like that it directly measures the stiffness of the liver. However, it has limitations, especially in patients with severe obesity, BMI above 40, and patients with very elevated ALT and AST above 200. And of course, there's congestive heart failure, things like that can affect your liver stiffness. So every test has limitations. But I would say in my practice, I do VCT on every patient. I do ELF in cases when I feel like there is discordance between the FIB4 and the VCTE. Then I do the ELF score. It doesn't mean that one test is better than the other. And each test, you need to understand the limitations and the context of use and the pretest probability. But again, in my practice, VCTE followed by ELF.
Dr. Akori from Ohio is awake.
Yeah.
Next question is to Dr. Gunn.
Oh, I was going to mention
Yes, please.
that you should do the test that you have that's available.
I like it.
I practice in a rural area, Gatesville, Texas, home to 5 of the 9 maximum security prisons for women in Texas. and it's a little bit under-resourced. So, so an ELF test may be the thing that our primary care physicians can get to, but I do agree, I love the elastography coupled with an ELF when there's discordance. And I also appreciate with the CAP score, because it's really something I can follow in real time with patients as they're losing weight, as they're making lifestyle interventions, and show them what's happening with their CAP score. So I don't want to say one's better, but
awesome.
You don't.
So we're getting the story that combine them, the more the better. It gives you the direction. Dr. Gunn, are dose adjustments of risk different needed at patients on statins?
Yes, it all depends. So when you have a patient who may be on, say, simvastatin or atorvastatin, if I'm not mistaken, you do need to dose reduce to about 40. And then if they are on rosuvastatin or, which is the other one, it would be no more than 20. But basically, the bottom line is those doses are very commonly used in practice. You're really seldom going to see someone on more than 40 of the ones I mentioned or 20 of the other. But you do want to make sure you're monitoring that those doses are within those ranges to avoid any untoward overexposure to the statin and susceptibility to myalgias, rhabdomyolysis, et cetera. But you will find it very few and far between that you would need to maybe dose adjust. But if you are going to dose adjust, I always recommend consulting with whoever prescribed the statin to ensure we're all on the same page and they understand the benefit that you're going to give the patient by adding the resmetirom therapy.
And honestly, the East Coast people are asking a lot of questions. I don't think I'm going to get to all of them, so I'm going to start choosing here and there.
They're fired up.
All right. Is liver biopsy not needed prior to resmetirom therapy? Naeem, quickly.
Yeah, it's definitely not needed. But again, if you cannot make up your mind with NITs, then please do the biopsy because our patients deserve to know what fibrosis stage they have. But I can tell you that in our practice, we qualify about 90% of patients based on VCTE. And then we have about 10% of patients that have a historic biopsy. Only about maybe 5% have a new biopsy to qualify them. So short answer, you don't need a biopsy.
You should have said that from the beginning. Anyways, back at you. Is semaglutide contraindicated in patients with cirrhosis? Tell me about the cirrhotic patients.
Yes, so I want to make it clear that, again, semaglutide and resmetirom are not indicated for patients with MASH cirrhosis. Semaglutide is not contraindicated in cirrhotics. So if you have a cirrhotic patient with type 2 diabetes, you think semaglutide will be helpful for the diabetes part, you can utilize it. However, the data we have in cirrhosis with semaglutide did not show a benefit on fibrosis stage, and it's not being developed as monotherapy to treat cirrhosis. On the other hand, resmetirom is not indicated for cirrhosis, but actually it's in a phase 3 trial called Maestro-NASH Outcomes that should read out in 2027. And that may lead to label expansion, and actually it will become the first FDA-approved medicine for MASH cirrhosis. So big difference here. But at the end of the day, for simplicity, today, both medications are not indicated, but they're not contraindicated.
All right, let's go to Dr. Gunn for this one. How likely is liver fibrosis, fatty liver, to return after stopping GLP-1? Because many patients regain the weight after termination of GLP-1.
Well, I don't know that we have the true answer to how likely they're going to revert back when it comes to their MASH presence, absence, or degree. But we do know when weight is lost by the GLP-1. Once you remove the GLP-1, patients often regain the weight. So I always tell patients, especially when they ask me, well, how long do I need to be on these medications, et cetera? This is a chronic disease. It's going to need chronic management. And so because these studies are still ongoing, we're going to learn more as years go by. I can't answer whether they'll revert back to where they came from if they started. So it's definitely a chronic crawl.
But a very good point. Patients regain weight after stopping GLP-1s.
Let me ask you guys a question. How many of you are going to AASLD, the liver meeting? Okay.
Yay.
Stay tuned, because we have some data that we will present on the recurrence of disease when you stop resmetirom in terms of ALT and some other biomarkers. So I encourage you to come to that.
Then answer this question. How long do you keep patients on resmetirom? It's right here. I'll show it to you.
Yes, so very good question. I think, with resmetirom, the key is that we want to assess response to treatment at the 1-year mark. You don't want to do it after 3 or 6 months, because that's too premature. I think, only in patients where you see clear futility, like your liver stiffness actually went up, the ALT is not budging, then you can stop. But I can tell you that this is only about maybe 10% of patients. Mm-hmm. You're going to have about 30 to 40% of patients where you see a clear response, everything goes down, ALT, CAP score, stiffness. And then the rest of patients are going to have maybe improvement in ALT, the CAP, the stiffness is the same, and we continue. I think we will have a much more clear idea when the Maestro-NASH trial concludes. At the 54-month, we're going to do a third liver biopsy, see how many patients progressed. So I think at this point, outside of the complete futility at the 1-year mark, I would continue and reassess on a yearly basis.
Very good. A lot of questions. I feel like we're getting questions from the fellows too because of the email, like the year. So I can't tell. By the way, any of the fellows going to hepatology fellowship, raise your hand if you're going to hepatology.
Just say you are.
Please do. One of you, please. Raise your hand. One of you.
They're
Okay.
very adamant.
I know that. That's how
Staying in the dark side. Okay, so this is a spicy one. What is your opinion of dual therapy with a GLP-1 and resmetirom for MASH? Should one be started before the other? Short answer, Dr. Alkhouri. Short answer, Dr. Gunn.
My opinion is that they both can be used in concert with one another. This is chronic liver disease that you're going to continue to manage and monitor your patient. When something's appropriate at one point, maybe you need to add something on later. So as far as one starting before the other, it all depends on the patient. But we know that GLP-1s, as you titrate them, they have untoward side effects, especially with the GI. And we know that with resmetirom, the GI side effects are really self-limited and early. So it'd be nice to go ahead and just get that started, get that out of the way. And then if you were going to consider a GLP-1, then do so after. But it all depends on the patient and what you're looking at, because some already come on GLP-1 at baseline. And so you may be adding the resmetirom later.
I don't think you can top that, but Dr. Akori, same opinion?
No, yes, same opinion for sure. Again, if a patient is coming to me on a GLP-1, even if it's not semaglutide and they still have MASH with F2, F3, typically I add the resmetirom. If they're naive, then it depends on several factors, including certain contraindications, like if they have history of medullary thyroid cancer, and then patient preference also, if they have a preference for pill versus an injectable. And patients also sometimes have their own opinions about the use of this medicine versus the other one. So always do shared decision making with the patients. Just give them the options and try to help them select the better one for them.
That's a good one. Is vitamin E still a good idea?
Is what still a good idea?
Vitamin E.
I'm impartial.
I mean,
Say no.
What, you
I
say
think-
no?
Yeah, I mean, there's no fibrosis data with vitamin E. It doesn't help with fibrosis. The Pivens trial showed maybe some improvement in disease activity. So when you have two medications that in phase 3 trials showed a reversal of fibrosis with the delta between 12 to 14% from placebo, I think it's a missed opportunity to start someone on vitamin E and wait. Vitamin E decreases liver enzymes, so if it relieves anxiety for patients, maybe, but I mean, I really don't think it's a good idea today.
I think that's exactly if the patient feels fine, they've been on it,
Yeah.
I'm not taking it away.
Makes sense. This is a very common clinical question. Is FibroScan superior to ultrasound elastography? What do you guys think?
Are you going to answer any questions?
You can, why don't you take that one?
I love to moderate.
Go ahead.
Well, I mean, I think, if you read the literature, it seems like they're very comparable in terms of the area under the ROC curve and, PPV and MPV. But I can tell you, at least in my own practice, we've had many patients come to us from radiology centers. They had ultrasound elastography, and they come terrified. It says F3, sometimes F4. We do the FibroScan elastography. It comes as F0, F1. I think the difference is with FibroScan, you're not selecting region of interest. The machine will also tell you if you're in a good spot or not. With ultrasound elastography, you can move that box, and I don't know if the operator is moving it too close to the liver capsule, and what other variables they can change. But this has been the issue. But in competent hands, they're comparable. In the real world, we've seen some overestimation.
Yeah, I would agree. And if it's all you have, right, if you don't have access to a VCTE, then by all means get the ultrasound elastography, and if there's any question, then we'll do a sequential, non-invasive to
Fantastic.
confirm.
I still have tons of questions. I probably should start wrapping it up.
The fellows
They're
are
all-
torturing us.
Yeah. If you guys have any other questions after this, just go to these two. And
Can I ask a question of all three of you?
yes, sir.
So
I have a question for the audience, but you go ahead.
you asked the audience questions. I have a question for all three of you.
Sure.
Okay, bring it on. So here, what we were talking about, I feel like obviously works really well when you have a tertiary care center, when you have access to healthcare, when I have GI experts such as yourself. How are we doing in terms of diagnosis, screening, and managing MASH in rural settings, in resource-poor settings? And then the follow-up to that was, what do you want to see more of from PCPs? What can PCPs do more of? Because not every place is going to have access.
That's an easy one, actually,
Love it.
because Dr. Gunn lives in a rural area.
That's
You want
what
to
I
answer
do.
that?
I saw her nodding. I saw the head nods.
You want to answer that? Please go.
It's all about, for me, I can speak for myself, but it's really all about education. We do something in our community called the MASH Bash. That
The
is
MASH Bash.
MASH Bash, and everybody is welcome. It is not just the clinician that prescribes. It is not just the person that sees patients. It's the waitress, the librarian, the person that's hotel staff. All of those people are welcome to come to MASH Bash to learn and then impart knowledge on their friends and family. Hey, mom, you've had diabetes for 10 years. You've never had your liver checked. I just went to this program and it was phenomenal. We learned so much. So it really takes all of us to share that knowledge and get people screened. And that FIB4 is so easy. Come on, it's so easy. And it's available. And even a patient can come to their doctor and say, hey, thank you for everything, but you didn't talk to me about my FIB4. And now you've imparted knowledge on the physician that's taking care of you. So that's our deal in a rural area.
I told you. We have an answer.
I thought you were going to tee up the answer. You did the perfect assist.
Here is the last question that I can answer to the audience and myself. Last two questions before I turn it back to you. Who's going to the bar next?
Water only.
Do you want us to answer that?
There are 3 people going to the bar. The organizers, they want to relax after that. Who's going to bed after this? Raise your hand if you're going to bed.
Fellows, I'll see you at the bar. Put your hands down.
Seriously, fellas, when I
Who's a
was
fellow?
a fellow, I didn't sleep. No, not really. But anyways, I'll turn it back to you, and hopefully we'll send people. It's midnight at the East Coast, so I'll turn it back to you for.
I'm gonna ask you one quick lightning round question.
All right.
In 5 years, when we all meet again, where do you want to? What advancements do you want to see in terms of MASH, in terms of therapy, in terms of NITs, anything in 5 years?
Advancement. I want to see some fellows going to hepatology and being a hepatologist.
Awesome.
I think the easy answer, we're going to have a combination therapy of multiple drugs. It's one, not one versus the others. It's actually, we think about it, finally answering a question. We think about it as type 2 diabetes. You start, you have SGL2s, GLP-1s, and then this, and I think that's what's going to be MASH, especially when we move to the cirrhotics. I think cirrhotics are, I call it elephant in the room, or it's the beast hard to beat. And I think there will be multiple medications, hopefully reversing cirrhosis, especially at early stages.
I'm trying to get stock advice from you, so that's good.
I think for me, it'll be nice to be able to design phase 3 programs without ever needing a liver biopsy and utilize the prognostic value of non-invasive tests. And then having FDA-approved treatments for patients with MASH cirrhosis would be great. So these would be my 2 wishes in the next 5 years.
And Dr. Gunn, in 5 years, I'm coming to the MASH Bash.
Well,
so
number one, that awareness is really good, taken off, and that we have maybe a preventative measure that we can keep people from getting it altogether.
I love it. And with that, thank you all for taking the time. Thank you for participating. Everybody needs CME, right? CME is in the house. Please scan this code. Let everyone know. Tell your friends that the Liver Lovers came through, but you're all welcome to come party with us in the bar, Hepatic Heroes, and Steatotic Squad, Steatosis Squad, Hepatitis Squad. I forgot your names are, but thank you all, virtual audience, for staying up with us as well. Please feel free and ask more questions, get autographs, ask for more investment advice about what combination therapies are going to be available. And with that, thank you all. Fellas, you're not going to bed, right? Just so you know.